Like the camera is on you and you're sitting normal and then you see it go. Hello everyone, how are you doing?
Hi, Doctor.
I hope you're all doing well. I'm very happy to meet you back in the fake Endodontic annual meeting at GSDM. Are we missing someone? Where's Dr. Rocio?
Dr. Rocio.
We have another one over here.
Dr.
Don't worry about it. Okay.
I see. I can hear the noise.
Yeah, it's Boston. No surprise.
So.
I'll do a Zoom meeting.
Okay. Good. So today we're going to be talking about the pathology of periapics, or what we dentists call periapic periodontitis.
Is that common, doctor?
Oh yeah, I'm glad you asked that. Actually, it is very common. A survey was done by the American Dental Association in 1990, and they found that 14 million endodontic treatment was done in that year.
Wow.
In the United States alone. And also, another research was done in the European countries and Scandinavian countries. They found that the prevalence of apical periodontitis among people in their 20s was 33%, and 40% in people in their 30s, and up to 62% for people older than 60 years old of age. So to start with, I'm going to be talking about anatomy. So as we know, the periapical tissue consists of the three main components: cementum, periodontal ligament, and the alveolar bone. The cementum has three types: two acellular type and one cellular type. The periodontal ligament is the specialized connective tissue that connects the cementum to the alveolar bone. The alveolar bone is the part of the bone of the jaw that house the sockets for the teeth. Apical periodontitis can be protective or destructive depending on the dynamic interaction between the microbe insult and the host defense of the periapical tissue. Evidence and studies suggest that by a conventional root canal treatment, you can reduce the amount of biofilm and bacteria, but you cannot eliminate it. So why I'm talking about bacteria? Dr. Jesse is going to talk about the etiology of periapical periodontitis.
Dr. Jesse. So thank you, Dr. George, for the introduction. I'm going to start with talking about bacteria. As you can see in our nerve system, if you have a decay like this one we're showing over here, you have bacteria coming from the oral area, oral mouth, and then go into our nerve system, and that's how our nerves get infected. There's two different ways: either inflamed or infected. If it's inflamed, you can see that our body still start to respond to those irritants. Like you can see some blood flow starting getting more, and then you can get a little bit sensitive. That's called inflamed. But when you get to a point where you call infected, then you can see some bony structure or tooth structure start getting destroyed, like our bone, our root, our cementums, etc. We're gonna quote a very famous doctor, Dr. Takahashi, who has his son here, Senji. And then he did some research about bacteria and how it affects to our periapical lesion. So you can see, he say, those bacterial infection from the pulp tissue actually, even though it's periapical area, that's caused the destruction of our bony structure. Not just bacteria, including any noxious substance like our degraded protein components and any other etc. things, and our host defense, and that can also be very harmful to our periapical tissue area. So as we can see, if you have a untreated root canal, the bacteria over here, based on this research, will be gram-positive, gram-negative, and obligate and aerobic. If you have a root canal treatment but also still have the apical periodontitis, and then based on this research, you can see it's gram-positive, facultative, and aerobic, and then the majority of this will be E. facialis. Okay, then how does this bacteria affect into those lesions? It's based on our host and fighting with the bacteria. It's called host and parasite versus parasite. So if it's our body, then you can see we have a tooth structure, which is very hard. It's physical barrier from dentin enamel, lots of hard tissue. Or we also have the immune system that's trying to fighting with the invading of the bacteria. And speaking of those immune system response, we're gonna give it to our next speaker, Dr. Rocio, who will give us a lecture about that.
Hi guys,
I hope you're doing fine. It was impossible for me to get to the meeting, but I hope we're gonna do just fine today. So, we're gonna talk about the innate immunity. And I'm going to start saying that the specificity of innate immunity is due to the recognition of pathogen associated molecular patterns of microorganisms by pattern recognition receptors, or they are also called toll-like receptors of the host cell. Activation of PRRs triggers numerous host responses, including opsonization, activation of complement, coagulation cascades, phagocytosis, activation of pro-inflammatory signaling pathways, and induction of apoptosis. And I'm going to be showing you different images so you can have an idea. For example, TLR4 is the receptor for the gram-negative bacterial LPS. In addition, LPS is shown to be capable of inducing pain via direct activation of TLR4-CD14 expressed on nociceptive sensory neurons. Thus, the TLR4 PRR receptor is importantly involved in odontogenic infections. Components such as lipoteitoic acid of gram-positive bacterial cells walls can also stimulate innate immunity in a way similar to LPS. I have all the images that I'm gonna be projecting as I explain so you can understand better. The innate immune response to bacterial infection induces expression of pro-inflammatory cytokines, chemokines, and co-stimulators, which are essential for the activation and influence of the nature of adaptive immunity. The innate immune system is capable of recognizing non-self and self-antigens, while the adaptive immune system does not. Thus, many autoimmune diseases are disorders of adaptive immunity.
So now I'm going to talk about lymphocytes and the cellular basis of adaptive immunity. Lymphocytes are a small bean-shaped structure that is part of the body immune system. This structure's main function is to filter substances that travel through the lymphatic fluid, helping the body fight infections and diseases. Lymphocytes are classified into T and B cells. T cells develop from the thymus, and B cells develop from the bone marrow in adults and from the liver in fetuses. There are two main classes of T cells. We have the cytotoxic T cells, and we also have the T helper cells. So how does adaptive immunity begin? We have a macrophage here, and this macrophage is going to interact with a pathogen. A pathogen could be a virus, a bacteria, and this macrophage engulfs the pathogen. When this happens, then part of the pathogen is now attached to the membrane of the macrophage. This engulfed pathogen needs to be presented towards our T helper cells. When this happens, a match needs to be done. And this is done by having a specific receptor attracting a specific antigen through CD4 cells. This T helper cell should be activated by replicating themselves. After they making copies, now there's an army of T helper cells which are going to stimulate inflammatory cells, they're going to stimulate cytotoxic T cells, and they're also going to stimulate the production of B cells. Cytotoxic T cells, or CD8 cells, are going to interact with the same antigen that they recognized previously. They're going to start multiplicating themselves, and they're going to fight those antigens by apoptosis, or destroying the pathogen. On the other hand, we have the B cells, which are going to make antibodies. They're going to start replicating themselves, and by doing that, they're going to differentiate into plasma cells. And these plasma cells are going to make more and more antibodies. According to a study, T cell deficiency appears to accelerate bone loss at the early phase of apical periodontitis lesions, but does not affect the overall course of lesions development. During another study in which they used mice, it was found that approximately a third of those mice used developed endodontic abscesses, while no immunocompetent controls had abscesses. Both had T and B cell deficiency. In conclusion, we can say that both T and B cells mediate the observed immune responses in apical periodontitis. So now we're going to have Dr. Hernandez.
To continue the role of adaptive immunity, we're gonna see how the afferent nerve fibers have an interaction in the apical periodontitis. They do this through neuropeptides, which will cause three different effects. The first effect is vasodilation. We have a second effect, coin protein extravasation, and we also have recruitment and regulation of immune cells, which include macrophages, mast cells, lymphocytes. This whole process is called neurogenic inflammation, and the main protagonists of this are CGRP neuropeptides, SP, and VIP. We have neuropeptides and receptors that are spread throughout the body. So when there is local inflammation, we will have an increase of cellular immunity that will cause sprouting of the nerve fibers. This sprouting of the nerve fibers will in turn cause more local mediators to affect the local site, causing neurogenic inflammation. The main protagonists of neurogenic inflammation are CGRP neuropeptide, SP, and VIP. CGRP and SP will cause vasodilation and extravasation of proteins. SP will cause macrophages through IL-1, IL-6, and tumor necrosis factor. This in turn will call T lymphocytes and will affect and increase the immunity of the inflamed site. We also have VIP, which will decrease osteoclastic activity when we have apical periodontitis. This is very important because VIP will block the release of macrophages through other interleukin molecules. CGRP and SP are important in apical periodontitis because they will both cause inflammation and bone resorption. And so we have this ability of the immune system to fight inflammation through neurogenic inflammation.
Okay, I'm talking about the diagnosis, and my dad already talked about this since I was 6 years old. Okay. So, as you know, histologic diagnosis is the definitive diagnosis, but it takes time, and most of all, we need to sacrifice tooth. So, I'm not sure your patient like this. So, we have another one, clinical diagnosis. This includes signs and symptoms, duration of disease, pap test, percussion, and radiography finding. The tricky part is apical periodontitis could be symptomatic or asymptomatic. This is because there are two parts. Some mediators or some cytokines or neuropeptides make it worse. But at the same time, endogenous opioid or somatostatins relieve the sensory endurance, so it could be tricky. Then let's move to the radiography finding. But radiography finding could detect only the change at tissue level, not the cellular level. So conventional radiography does not detect the subtle inflammatory change in the apex. So, therefore, according to the Dr. Lind article, there is no good correlation between the clinical symptom and histological diagnosis. So what should we do? Anyway, we should be mindful that absence of clinical symptoms and negative radiographic finding does not always indicate absence of apical periodontitis. Let's move to the histology part. Dr. Ahmed will talk about this.
Thank you, Dr. Sanjay.
Great to see you.
Good afternoon, everyone. My name is Dr. Ahmed El Sayed. Today I'm going to... Okay, so in acute apical periodontitis, we're going to see a lot of neutrophils, macrophages, and lymphocytes. Okay, so also another thing important in apical periodontitis is the abscess formation. The abscess is basically, remember the battle Dr. Jesse talked about? The abscess is the end product of that battle. It's about toxins, dead neutrophils, and pus collection. And here, we have a very nice picture taken by Dr. Domenico. It shows the pulp part of the tooth with the periapical part of it, and you can see here the spread of infection and the formation of periapical periodontitis right here. And if we zoom out at this part, we can clearly see the osteoclast effect on the bone causing internal resorption. Thank you.
Actually, I was expecting more from you. Like, you should have brought some kind of dinner, like steak, something, lunch. Like,
Oh, sorry, I was partying hard yesterday, but let me call my assistant. Let me call my assistant and tell her to bring something for me.
you need to do something about it.
Okay. 3, 2, 1, action.
Hi, everyone.
So thank you, Dr. Rosillo. Now I'm going to talk about lymphocytes and the cellular basis of adaptive immunity. Lymphocytes. No, Pedro, porque after I say that, you have to be here. So that will shock when I say now I'm going to...
Dr. Alicia will talk about this.
Alicia.
Diagnosis? Is that your topic?
Yeah, it's a diagnosis.
Oh, diagnosis.
Yeah, yeah.
Hey, that's good. Is that a topic? Our colleague.
Thank you.
Oh, yeah.
He's doing
Unofficial recording.
Dr. Julian Kakehashi, how are you?
Good, how are you?
I'm great to see you.